Welcome to Didactic Residency Edition. I'm Dr. O'Leary, and I have a special guest for you today. Introduce yourself.
Dr. DePietro.
Hello, Dr. DePietro.
How's it going? Thank you for having me on.
I've never had a guest on my podcast before, so this is very exciting for me.
First guest.
Awesome. And what are you here to talk about today?
So we're going to talk about bipolar depression treatment.
Okay, so not just bipolar depression, but like treatment of bipolar depression.
Yes, exactly.
Okay. Tell me why this topic means something to you.
So I think what's interesting about it is just by way of background, we're residents together, so I'm still in training as well. But I think bipolar depression is often talked about in a way that is like confusing and people have a hard time understanding like how are we treating it, and that's for a variety of reasons that we'll get into. But I think it's kind of botched a lot of times in training. So I think kind of characterizing what are our options and what is the strength of the evidence behind those options can be really helpful.
Yeah, absolutely. Like when I think of bipolar, I think of mania, right? And then how to treat mania. And there seems to be, pretty good evidence for a lot of treatment of mania, but treatment of bipolar depression, that's difficult. It's not the same as regular depression, and I think we'll get into that today.
Yeah, we are going to get into that, and I think the first thing that I like to keep in mind is that you're not just treating bipolar disorder. Like I think a lot of times we think, okay, this is a disorder, it requires a treatment. We're treating things in a phase-specific way. So treating mania is not the same thing as treating bipolar depression, which is not the same thing necessarily as treating unipolar depression. All right, so I guess we should get started by talking about what is bipolar disorder. So just by way of background, it's a complex and very serious illness that can be life-threatening, where people cycle between what we call depression, which most of the audience is going to be familiar with, and mania, which in some ways is like the opposite of depression, but they can have definitely overlapping features. And then in between episodes of mania and depression, you have what's called euthymia, or basically feeling normal. Today I want to talk, though, more about treatment rather than the disease itself or diagnosing it. So when talking about treatment, we have to know the variety of options. There's therapies, there's medications, there's neuromodulation, and all of these have a role in how we treat it.
Okay, I love it. So let's just focus today on like bipolar depression, because that really seems like a lot harder to treat than mania. We have our protocols for mania, but like bipolar depression is hard.
Yeah, so I think that brings us to the first point about treating bipolar depression. Bipolar disorder is treated in a phase-specific way. So it's not just, I start a medication for bipolar disorder. It's I treat bipolar depression, bipolar mania, or I prevent bipolar depression and bipolar mania. And I think that's the biggest confusing thing, is that you don't just start things in a shotgun way. This is for bipolar disorder. You're treating specific phases. And I think one reason there's confusion surrounding this is, there's several reasons. And I think one problem is that when talking about bipolar depression, we typically don't start with antidepressants. And that can be confusing because of the language. And we'll talk about that a little bit more in a bit. Another reason is some of the drugs we use in one phase, or as maintenance in bipolar disorder, aren't useful in bipolar depression. A good example is Haldol. Haldol is like really effective for treating mania, but it actually can induce bipolar depression.
Yeah, agreed. Like Haldol is not really the most motivating drug, and really can also interfere with executive functioning and things like that. So tell me more.
So, yeah, exactly. So, and I think the third point of confusion with bipolar disorder and its treatment is this concept of a mood stabilizer. It's the word we're stuck with, so I get it, but I hate the concept because it really is kind of vacuous and nobody has a good definition of what it means, either clinically or pharmacologically. And I think it implies that it's, this is a drug that works for bipolar disorder. Well, maybe it does, but which phase? Is it treating depression, treating mania, etc.? And also, people can have mood lability, for example, in borderline personality disorder, without having bipolar disorder. And does a mood stabilizer work? Well, I think it can be misleading. You think, the term seems to apply, but that doesn't mean the agents actually work for these other conditions.
Right, and so what we're talking about here, just to be clear, we're going to talk about the acute treatment of bipolar depression as opposed to anything else. So we have to be very clear of what like medications we're using for bipolar depression in the acute phase.
Yes, exactly. So the acute phase is somebody with a history of bipolar disorder comes in your office or an inpatient and they are currently depressed. And what do you do to treat them? And so bipolar depression is similar to unipolar depression as a clinical syndrome, and according to the DSM, they're clinically indistinguishable. And you have that patient in front of you, you diagnose them, and you say, okay, how am I going to treat them? And I think before talking about any specific treatment, you have to be mindful of general treatment principles. And the first would be that safety is the number one priority. So is this patient suicidal? Are they neglecting themselves? Do they need to be hospitalized, etc.? Are they catatonic? Because these things can really be life-threatening.
Yeah, and we're talking about like a lot of dysfunction, and the dysfunction can happen now, but also in the future. So how do you plan for maybe future dysfunction while you're treating in the acute phase?
So I think it's important to be mindful when you are treating in the acute phase that this is a chronic lifelong illness. So although bipolar disorder treatment is phase specific, you might go down one approach, like one path, because you're looking down the long game, right? So you're thinking about how does this treatment affect the long-term course of bipolar disorder. And so, for example, the goal of treating a bipolar acute depressive episode is to treat to what we call remission, or what that basically means is back to normal mood. And one reason we do that is because we don't want people to have normal mood. We want them to be better. But another reason is because residual symptoms actually predict worse long-term function. So that's kind of combining when you have a patient with an acute bipolar depressive episode. How are you going to treat them right now? Well, you have to be mindful of the goals of treatment because of how it could affect the future. And I think doing that involves a lot of different techniques, and it's a lot of personalizing your treatment options for the particular person in front of you.
Right, like we can't just follow a protocol. There really aren't protocols, like good protocols for bipolar depression. We really have to pay attention to the patients.
Exactly, which is one reason why things like psychotherapy, establishing rapport with the patient, offering encouragement and support, and are all really important features of getting the person who is depressed well.
Yeah, I agree. Keeping patients engaged in treatment and even in therapy kind of as a lifestyle, it's really critical in bipolar disorder, especially because it's a chronic illness.
Yes.
It's not going to go away, and they need to have a place that they can go and get treatment.
Yes, exactly. So therapy has a definitive role in the acute bipolar depressed phase, but also if you have someone who has bipolar depression and they come to you and they're acutely depressed, the therapy can play a role short term, but it can also help long term in terms of helping with like adherence to medications and things like that. But if you have someone who comes to you and they're depressed and you're thinking about starting a medication, which is often considered the first line for this disease, before picking a medication, you have to figure out like, okay, how am I going to use this medication? Like, how long am I going to use it for, etc. So the first principle, as I said, is like you treat to remission. The second thing is, okay, you have a patient, you're starting a treatment, you get a medication to an effective dose, and even though the medication might take 4 weeks to kick in, you really should be monitoring pretty early on how well they're doing. And one reason is because of that therapeutic alliance, and another reason is because if a patient doesn't get better at all within a week or two, that means they're probably not going to get better at that end of that classic 4 to 6 week trial.
So do you mean like we should look for partial responses within like 2 weeks?
Exactly. So I think that really does help with building that therapeutic alliance, but it also helps in, okay, they're 2 weeks in, they haven't felt at all better. You don't wait for that end of that trial. You say, this has failed. On the other hand, if they do have kind of a partial response, you can be optimistic and encouraging, like, hey, the patient, Mr. and Mrs. So-and-so, like, we've seen you get better, and I'm optimistic that over the next several weeks you'll continue to get better. So in any case, you do your if they get a little bit better and now you continue out a 4 to 6 week trial, that's a complete trial. So if they're not in remission, you can say that's when you go to the next option, or if they're in remission, that's when you've completed the acute phase of bipolar depression.
So we're looking at like 1 to 2 weeks for a partial response, and then waiting up to 6 weeks before we kind of determine whether or not they're having an adequate response.
Yes, exactly. And then once you say they have an adequate response, you've done the job, and then we can talk about maintenance therapy. But that's another episode.
Okay, so what are actually the drugs that we use for bipolar depression? Because I don't think they're the same as they are for depression, right?
Yeah, for unipolar depression, they're different. But I think before talking about any of the drugs, I just caveat. A lot of the studies we look at in bipolar depression are for bipolar 1 disorder. So a lot of times we're inferring things about bipolar 2. For those who don't know, bipolar disorder 1 and 2 are versions of the same illness, but slightly different in terms of how mania presents. And the second point is most of our bipolar depression, or our bipolar patients in general, are already on several medications. So even though a lot of the studies are monotherapy or one drug, we have to infer what that means for combinations, because that's more real world.
You mentioned briefly earlier there's some definitional problems with bipolar 1, but there's even more with bipolar 2.
Yeah,
so, okay.
So, in any case,
So what do we have as far as like
our
evidence
menu
for bipolar in general so far?
So on our menu, I think the best way to conceptualize this is to start with what the FDA has approved. That doesn't mean these are the only effective medications or that they're the most effective, but I think it's a good way to start. And there are 5 options. In no particular order, there's the combination of olanzapine plus fluoxetine, which is sold under the brand name Symbyax. There's quetiapine, lorazepam, cariprazine, and lumateperone, which is the newest of the options.
Okay.
Lumateperone is unique in that it is approved specifically for bipolar 2 depression. Quetiapine is a little more open-ended, so it's like just for bipolar depression in general. The others, I think, if I'm not mistaken, are bipolar 1 specific. And you'll notice all of these medications are antipsychotics, or in the case of olanzapine and fluoxetine, it's a combination with an antidepressant. But that's, I think, worth noting. And the second thing is the first two, the olanzapine, fluoxetine, those drugs are both available as generic, and quetiapine is also generic, so they'd be cheaper than the latter 3 that I mentioned.
All right.
So I guess we'll start in that order. So olanzapine plus fluoxetine, Symbyax, is an interesting combination. And of course, it doesn't have to be given as Symbyax. You can give each drug separately. It was the first to be approved, and it was approved based on a study, a very large study. They involved like 700 or so people. But it's interesting because in the study, it was 350 or so people in the olanzapine arm, 350 who got placebo, and then only about 70 who got the actual combination.
Wait. So only 70 got the Symbyax?
Yeah.
Okay.
Exactly.
Keep going.
So it's really large. So if you hear the study, you're like, oh, wow, that's huge. But in reality, the actual drug that got approved, only 70 patients. And the I think the reason is because the drug company was actually looking to get olanzapine approved for bipolar depression as well. But the problem was when they did the study, olanzapine did work for bipolar depression. It did decrease symptoms on a scale called the MADRS, which is a typical scale we use to measure depression symptoms. And it did work. The problem was it improved the symptoms in depression associated with appetite and sleep. So, as you might be aware, these symptom scales measure a lot of distinct symptom clusters. So in depression, since people's appetite and sleep are often messed with in one way or another, they're in those symptom scales.
So they made their mood might not actually have been improved. Okay.
Which is why olanzapine alone, even though it was better, statistically significantly better than placebo, didn't get the FDA approval for bipolar depression. But olanzapine plus fluoxetine, even though it was a very small number of patients relative to the others, did get FDA approved because it did help not only with that sleep and appetite, but it helped with the mood as well. However, I think the caveat is if you look at that study, you might think, wow, olanzapine plus fluoxetine had a really robust effect compared to placebo, which it did, but if you look, a big chunk of that effect was due to the fact that the olanzapine in that combination helped people with sleep and appetite, which are important, but they're not the same as treating the core of the illness.
So, Dr. DePietro, tell me a little bit also about quetiapine.
Right, so I think that's the next drug for bipolar depression. There's a lot of data that supports its efficacy, and some alone and some in combination with drugs like lithium and even lamotrigine. Depending on what study you look at, it's a drug that shows like a number needed to treat around the 4 to 7 range with a moderate effect size. So it's a pretty reasonable option, and it has some long-term maintenance efficacy as well.
Yeah, I mean, 4 to 7 is pretty good. And let's move on to lorazepam. Tell me about lorazepam. It's expensive, right?
Yeah, lorazepame's a little newer, probably similar in efficacy to quetiapine, a little less sedating, which gives it an advantage there, but has some more extrapyramidal symptoms, so that can be a downside. Not as well studied as quetiapine, but still a good medication. And also, I think of interest, something people don't mention a lot, but it's the one drug that exists that has ever been studied in unipolar depression with mixed features, and it had a pretty impressive result. So just a shout out to that.
Does it have head-to-head trials with quetiapine? Because I hear quetiapine a lot, on other podcasts.
Unfortunately, it's hard to find head-to-head trials of much of anything. Every now and then you'll get lucky and find one, but no, there are none that I'm aware of, at least. Although I could be wrong. But lorazepame's pretty new, so I wouldn't be surprised if there was nothing there. And so that's why you have to be careful about making comparisons between these drugs across studies, different patient populations. You'd have to do that more formally in a meta-analysis. But that said, they seem to be probably similar in efficacy. And I think also of interest is lorazepam on its label. It actually is not only approved as monotherapy, it's approved in combination with lithium and valproate.
Okay, so it can be used pretty easily with we don't like to use the word mood stabilizers, yes, but what are traditionally exactly. Mood stabilizers, not necessarily treating depression, like taking depression to a stable state, but really mood stabilizers mostly mean taking a manic state and pushing it down toward a more euthymic or even potentially depressive state.
Yes, exactly.
Okay.
So another drug for bipolar depression is cariprazine, and actually that's one of the drugs that does have some anti-manic and antidepressant effect. I think its data is less compelling than with lorazepam and quetiapine. Its number needed to treat in one study was 10, which is not that great. And the other thing is the marketing gimmick of cariprazine, if you've seen any of the commercials, which it's likely that you have, is that it treats the mania and depression. And I think that's kind of a misleading gimmick.
Okay, well, I actually don't watch TV, so I haven't seen them, but it's not surprising that drug companies are trying to fool us into prescribing a medication.
It's not that they're lying about the product or anything. I mean, it's perfectly above water stuff. It's just that it's not that clinically useful. See, if mania and depression are distinct phases, a drug that can treat both acute phases, that's nice in theory, but what does it mean for a patient in front of you who is always either depressed or manic? And of course you can have mixed features, meaning symptoms of each, but that's often categorized sort of in its own way and studied actually in its own category. So the fact that a drug treats acute mania and acute depression actually isn't that exciting. What would be much more exciting is if it prevented both depression and mania. And the other aspect of that is it treats both mania and depression at different dosages. So it's it's the same drug. So if the patient, happens to have these pills, that's helpful. But if you're treating depression at lower doses and mania at higher doses, you're not even doing the same thing. And in fact, the higher doses, there was one study that showed that the higher doses were not effective for depression, whereas the lower doses were. So that makes it even less of an exciting thing, even though that's what the marketing tool being employed.
So if you're using higher doses, though, that could result like potentially in like a lot more side effects, right?
Yeah, so the big one would be akathisia early and probably some other extrapyramidal symptoms late.
Okay, so like we get extrapyramidal symptoms if you try to treat people with like a high dose of cariprazine, especially.
Yeah,
okay.
Absolutely.
So tell me about lumateperone. Is that how you pronounce it?
Lumateperone, I think. I don't know. Caplyta is the brand name. And actually, that in the studies for schizophrenia and bipolar disorder, there have been no extrapyramidal symptoms that have been observed above the rate, like at rates higher than placebo. So that's promising there. But it's so new that I don't want to make too many comments on it. Like, the jury is still out. I think, based on the data, it's probably going to end up being one of in the mix, similar to lorazepam, quetiapine, but maybe a little better tolerated. There's no maintenance data on it. There's no mania data on it. So it's kind of a mystery box at this time.
So does that mean we really have only like 5 options to treat bipolar depression? Please say yes so I can solve all my patients' problems or like other residents by giving them a mnemonic like Quackle or QCLOL or something that they can remember these 5 drugs by.
Well, if those 5 drugs really were slam dunk drugs, then maybe. But unfortunately, as like it's kind of apparent, they're all mediocre kind of. So other drugs have been studied. The other quote unquote mood stabilizers, lithium, valproic acid, or carbamazepine, all have been studied. They all have a lot of limited data. Lithium in particular has great maintenance data, and many experts think it is effective for bipolar depression. It helps prevent suicide. Long-term studies show that lithium is great in all sorts of outcomes. So it really is a great maintenance drug, and it has some acute bipolar depression data to support it, but also a lot of data to refute it as a treatment.
Yeah, I hear about lamotrigine a lot.
Yeah, so that's the one of the traditional mood stabilizers, if you want to call them that actually did get looked at the most. So valproic acid and carbamazepine maybe have some weak and controversial and kind of mixed data, so I won't talk about that too much. But lamotrigine is interesting. Huge myth that people always talk about is they say lamotrigine is an effective, established treatment for acute bipolar depression.
You mean it's not?
No, it is absolutely not. So it is FDA approved as maintenance, and it is approved as maintenance because it showed that it prevented bipolar depression in the long run. But in several studies, it actually did not beat placebo for bipolar depression.
Okay, so let's stop, because we talked about in the beginning that we're going to treat bipolar. We are going to talk about treating bipolar depression acutely, but you're saying that it could prevent bipolar depression, but it won't treat it in the acute phase.
Yeah, and the reason I mention that is because I think that's the genesis of this myth for lamotrigine being a treatment for acute bipolar depression. And in fact, they tried to get the FDA approval for that, and there were 4 negative studies. There was one positive one, and when all of those 5 studies were pulled together, there was a small, very clinically modest effect that showed lamotrigine might be a little more effective than placebo in acute bipolar depression. But you have to take that with a grain of salt, because that's all on the strength of one study, not the other 4, which showed lamotrigine didn't work.
So we had one study kind of overpowering a meta-analysis to...
Yeah. And so if you remove that outlier, it shows lamotrigine's no better than placebo. Now, there are some small studies that show lamotrigine plus quetiapine, lamotrigine plus lithium might be effective. But I think lamotrigine is very much limited by the fact that the dose titration is very slow. So it takes a long time to get to the therapeutic dose.
And that's because we want to prevent like Stevens-Johnson syndrome, the big rashes, like horrible things happening to people.
Exactly.
It's hard to explain that, I'm sure, to patients sometimes.
Yeah, so I think lamotrigine, worth talking about in the maintenance phase, but for treating acute bipolar depression, it certainly isn't established. Now, if someone says, this might have an effect, they're not basing it off nothing, but the truth is more nuanced, more subtle, and less certain than a lot of people will tell you.
What about some other things? Because, I've done some episodes on ECT, so I'm a little biased toward it. Can you tell me a little bit about maybe like ECT as an effective option for acute bipolar depression, or maybe especially for like suicidality?
Yeah, so I'm glad you brought that up, because ECT, while not a pharmacotherapy, is the gold standard for treating bipolar depression.
Wait, so we have a gold standard. What does that mean?
So I would say it's the gold standard in terms of efficacy, meaning and not all of these drugs have been directly compared with ECT, but the numbers for remission in ECT are just much better. And this is true of unipolar and bipolar depression when you look at ECT studies.
For the acute phase.
Yes, for the acute phase. We're not really sure how to prevent depression with ECT, and that's kind of another discussion. But so it's really not established, like you get a patient better with ECT, what do you do after that? There's still a lot that's up in the air there. But for acute depression, especially when there's suicidality, self-neglect, and treatment resistance, ECT is, or psychosis, ECT is absolutely the best treatment.
Okay, but I've read about other things. I mean, I totally, I'm going to put myself behind ECT because, I think people should think of it more often. And it's often not available, and that's why we don't. But if you have someone who's severely depressed and suicidal, think ECT. But I've also been reading about other things, that are not ECT and nothing that you've listed so far. Can you tell me about some of those?
Yeah, so there's other stuff more commonly thought about in unipolar depression. That's like TMS, ketamine, thyroid hormone. And in bipolar depression, there's some talk about pramipexole. These things are interesting, but they're pretty speculative at this point. I think often we shouldn't go, chasing these things based on the fact that ECT works. ECT is old, established, trusted and true. These things are new, exciting, interesting, but nowhere near as established.
Okay, so and then what I find really absent from your analysis of treating bipolar depression, aside from fluoxetine in combination with olanzapine, are other SSRIs. So what's up with this?
So I think I haven't mentioned this because I think it's the most controversial and involved part of this. So antidepressants in bipolar depression. Just because something is called an antidepressant doesn't mean it works for bipolar depression.
Really?
Our language for things is just a coincidence. It doesn't mean anything about their use.
Seems like bipolar depression is not a totally different type of depression than bipolar.
It's weird because clinically it does look very similar, and people try to pick out, are there some subtle differences, but the underlying illness is very different. And so one thing that comes up a lot among trainees that I really want to dispel is this notion, that this myth. People think, antidepressants aren't used in bipolar disorder because they cause mania. But they're an effective treatment, so we should be using them, and we should just mitigate the risk of mania by adding a anti-manic drug.
But shouldn't we?
So, here's the thing. I think that approach underestimates the risks and overestimates the benefits. So, in terms of the benefits, it's not established that any antidepressant works as monotherapy for bipolar depression, or that any antidepressant, any of them, works in combination with any other drug except for fluoxetine with olanzapine as part of a drug cocktail. So
I'm not going to be I'm going to give you some risperidone and add on a little bit of Lexapro just to...
No, that is not established. And there are, I think, good clinical and theoretical reasons why the particular combination of fluoxetine plus olanzapine would be the only effective one. And, of course, that's leaving aside the controversy of that study, which we already discussed.
Right. Well, there aren't that many studies, right?
Yeah. But I think so. There's no established data whatsoever that shows that any antidepressant, alone or in combination, other than that one, is actually effective for bipolar depression. I think the other thing is that statement that antidepressants cause mania but treat depression, but we can prevent that mania by adding an anti-manic drug. As I said, it over or underestimates the risks. Yes, adding an anti-manic drug like an antipsychotic can decrease the risk of having an antidepressant induce mania, but it doesn't get rid of it entirely. And I think the other thing is antidepressants have other risks besides inducing mania. So they can, one, cause mixed features. So they can cause subclinical, like subthreshold manic symptoms without causing mania. And another risk is mood destabilization. And this is maybe more of a chronic risk, but it's still something to be mindful of in the short term because patients often stick on these drugs, even if not super long term, for several weeks to months. So mood destabilization is basically you end up having more frequent episodes of depression and mania over a shorter period of time. And there is good data that's been replicated that antidepressants can worsen that, what's called rapid cycling. So it actually can cause, even if it brings you out of the depression in the short term, long term it actually starts causing more and more episodes of depression that are harder and harder to treat.
Yeah, that sounds like it really sucks. I mean, rapid cycling, mixed features, these are super hard things to treat, like, and they cause tons of dysfunction if you go from like one dysfunction to another and you have no euthymia in between. So, like, do you really recommend never using antidepressants, maybe other than like olanzapine plus fluoxetine?
Well, I think first, do no harm, and we know of at least 2 very serious harms that antidepressants can do, and it's not clear that preventing mania by adding an anti-manic drug to an antidepressant does anything to prevent rapid cycling. So I think there's a lot of risk, and as I said, there's no real good evidence to support these drugs, except for, there's some weak and some controversial limited evidence for some of them other than the olanzapine fluoxetine combination.
Okay, so like do no harm. It sounds like you're saying that like the risk of harm, it really outweighs the benefit. And but what do you say to folks who point out like maybe that there are some meta-analyses that show a small benefit of antidepressants in bipolar disorder?
So I think that's interesting because if you go on UpToDate and you read about this, you'll find probably a more positive view of antidepressants in bipolar disorder than I'm portraying. And I think the reason for that is there are several meta-analyses that do show a benefit. But these meta-analyses are only as good as the studies they're including. So if you look at them individually, what you'll find is a lot of them include older studies using totally different antidepressants than the ones we're using today, like monoamine oxidase inhibitors. Another problem with them is they're relying heavily on that olanzapine fluoxetine study, which I already mentioned. Now that study gets a lot of sort of its boost, as I said, from the fact that olanzapine treats the scale for depression very well. It's sedating and it's appetite stimulating. So, and yes, the fluoxetine added to the olanzapine helped the mood components, but still, I think what we're missing is the effect of that is probably overblown based on the olanzapine component. So, what that says is these meta-analyses that are relying on that one study or a few others that are older and not that good are actually looking better from a meta-analysis point of view than, or I should say, they make antidepressants look better than what they actually are. How we don't.
Are you saying, Dr. DePietro, that our meta-analyses can be misleading?
Very misleading.
Okay, all right.
So I think the bottom line that if I had to go with something is the antidepressants really don't have any established use in bipolar depression, but there probably are a subset of patients who might benefit.
Okay, let's summarize. So someone comes to you right now. I want to know. Like I have bipolar disorder. I've been on maintenance therapy for a while, but I suddenly go into a depressive episode. What do you start first?
So I make sure they're in psychotherapy because I think that's important in its own right and in supporting their long-term recovery. I think, is there a safety issue? Do I need to hospitalize you? And if it's super severe or they've tried other things that haven't worked or any number of other reasons, I might go with ECT first. That is the best, but it does have some significant drawbacks So if I'm talking pharmacotherapy,
But doc, nobody's gonna. I mean, I live alone. I get government assistance. Like nobody's gonna drive me to ECT at the hospital. Like I can't get picked
that
up.
has
Like
some
okay, so
drawbacks.
give me some meds,
So-
doc. I
so
can take
some-
home with me.
some
What
meds-
what do I do first?
So I think it's best starting with one of the FDA approved options, not necessarily because they're FDA approved, but because they have a good evidence base. And then you have to balance the cost and the data. And I think
Give me a
and the side
med. Just
effects.
choose one. I
Quetiapine
need
or
one.
lorazepam, and
Okay.
it depends on how your sleep is and how concerned are we about you gaining weight versus how concerned are we about you getting extrapyramidal symptoms.
Okay, so gaining weight. Which one would you avoid for gaining weight then?
Quetiapine.
Okay, and then like if your sleep is bad, which would you give?
They're both somewhat sedating, although quetiapine's better for that. So I think generally I start with one of those two and go from there.
All right, so it sounds like maybe quetiapine or lorazepam are your go-tos, but you have to also, like you mentioned before, really look at the patient, take the patient into account, look at the side effects, and you have to, of course, like a lot of patients with bipolar come to us having already trialed many other medications. What would you say to someone who says, okay, my patient trialed these medications, they failed in the past. Is that a reason not to give it in the future?
Depends why they failed. I think, was it lack of efficacy for bipolar depression? Was it lack of efficacy for something else like mania? Was it they didn't tolerate a side effect? It all depends, and it would depend what my other options were. And I think I would go from there.
Thank you so much. This has been a great conversation. I'm so glad that I had you on. I'm excited, and I think we should do this again. How do you feel about this? Do you think we should do this again?
Absolutely. I really enjoyed that, and I think it's easy to get into the weeds of the specific studies and that kind of thing. I think the biggest take home from this that I really care about, and I think is getting rid of the idea that there's mood stabilizers. It's phase specific, and I think even if you're not sure about which drug to pick, I think the best place to start is not by thinking about, what's a quote-unquote mood stabilizer, but what actually helps the patient I'm with today. What are their symptoms, and what can I actually do to help them out? And be really careful if you're considering antidepressants. They can really do a lot of harm, even if you don't switch them into mania, even if you think you're taking necessary precautions. They can cause a lot of harm over time.
Thank you very much.
Thank you for having me on. I really enjoyed it.
Yeah, well, this has been an episode of Psydactic, Residency Edition. Until next time. Hi, this is Dr. O'Leary. I've never done this before either, had a postscript for one of my episodes, but I just wanted to talk to you a little bit about what just happened. First, I would love to get some of your feedback. We have a website available. It's www.psydactic.com. That's psydadtic.com. And on there is a form you can fill out, and you can let me know what you think. If you like this episode or any of the other episodes, if you have suggestions, or if you're a resident and you actually want to maybe appear on this podcast, you can fill out that form. Also, I wanted to give a little quick disclaimer. Tom and I, or Dr. DePietro and I, are both part of the same residency program. We are in the National Capital Region as a part of the National Capital Consortium Psychiatry Residency Program, but none of us speak for that program. In fact, this podcast is just a personal project of mine. Whatever opinions are expressed here are my own or the opinions of my guest, and they should not be confused with the opinions of anyone else, whether it be like the American Psychiatric Association or the federal government or the Department of Defense or our residency program or anyone else. So these are our opinions. Let me know what you think of them at www.psydactic.com. Have a great day.